Yeah, good evening, everybody. Am I audible?
Yes,
Hemant, you're audible.
Yeah, good evening, Justin. Good evening, everyone who's around.
Good evening,
Welcome to today evening's program. And as usual, with every Procon debate, we try to make it as interesting as possible. Today, we have very interesting Procon debate, followed by a journal club. So today's Procon debate will be on restrictive target is the way to provide oxygen therapy in critically ill patients. It will be moderated by Dr. Sheikh Arif Pasha. He is the professor and head in critical care medicine in NRI Academy of Medical Sciences, Guntur. Over to you, sir.
good evening all, and thank you, Dr. Hemant, for your kind introduction. And at the outset, I thank the organizers, Dr. Ajit as well as Dr. Pradeep, for giving me this opportunity. So, as Dr. Hemant said, it's really today's topic is really debatable and very interesting with our two youngest stalwarts as well as our journal club also. So, because we are talking about this oxygen therapy, which is the most common intervention in the critically ill patient, because it has to be treated as a drug and must be prescribed in a proper dose, that is as a proper flow rate, duration and technique, and target should be specified clearly, because both the extremes of hypoxemia as well as hyperoxia have the potential to harm the critically ill patient and versus the outcome. So now today's topic, which is restrictive targets is the way to provide oxygen therapy in the critically ill patient, is debated by our two younger stalwarts. One is the FUR is regarding this pro by Dr. Saeed Nabil Muzaffar, who is an associate professor in the critical care medicine, King George Medical College, Lucknow. And it is this topic is againstly spoken by our Dr. Natish Prabhu, who is an associate professor from St. John's Medical College, Bangalore. So, now I'll invite Dr. Syed Nabil Muzaffar to take the pros regarding this topic. Over to you, Dr. Syed. So, before initiating, so we know this, each topic pros and cons is given a 15 minutes time each. Okay, after that, we can have a rebuttal of around 5 to 10 minutes. Yes. Kindly stick on to the time, please.
Sure, sir.
So that we can have a better discussion. Thank you. It's over to Dr. Syed for the pro second.
A very good evening to all of you. Myself, Dr. Nabil, and today I will be speaking in favor of conservative oxygen therapy in ICU. The learning objectives would be a small discussion about physiology, then coming to hyperoxia in ICU and its effects in different subgroups of critically ill population. Something about the evidence that has come up in this field regarding conservative versus liberal oxygen therapy. Then something about severe adaptation to hypoxia. Finally, summarizing the evidence in regarding how to apply conservative oxygen therapy in ICU and some take-home messages. So as we know that hypoxemic respiratory failure is commonly seen in ICU, and in a one-day point prevalence study, hypoxemia was seen in as many as 50% of ICU patients. The common reasons are, as per the alveolar arterial gradient, either a high altitude hypoventilation or in the diseases which lead to an increased alveolar arterial gradient like vacuum dispatch, shunt and diffusion defect, which are commonly seen in ICU patients. And oxygen therapy is the mainstay of optimizing oxygen delivery to the patients, which besides cardiac output depends upon arterial oxygen content. And by giving oxygen therapy, we are trying to improve the arterial oxygen content of our patients. So with this in mind, so is more oxygen better, or is it the more the better, or the more the merrier? So what should be the right oxygen therapeutic goal in our patients? Should it be hyperoxia? So coming to that from physiological point of view, we have seen that supranormal oxygen delivery has not been found to be superior to normal oxygen delivery in resuscitation of shock. And moreover, a landmark study that came up in 2008 by Evert de Jong and colleagues in 36,000 patients in Dutch ICUs found that there was a U-shaped association between hypoxia, not only hypoxemia, but also hyperoxemia with with an average hospital mortality. This was of arterial pressures of oxygen within 24 hours of admission in ICU. And coming to the history of oxygen since its discovery in 1774 by Mr. Joseph Priestley, within a decade, reports of oxygen toxicity started appearing in animals, followed by reports of oxygen toxicity in humans by early 20th century, with papers even coming up in journals showing oxygen is harmful. So this makes us to think whether oxygen is friend or in fact it is our enemy. So what makes it so harmful? What is the pathophysiology and what is the cutoff for defining a patient with hyperoxia? So in a review article by Singer and colleagues in 2021 regarding the definition of hyperoxia, any supplemental oxygen more than 21% is considered to be hyperoxia. Hyperoxemia is, although it is not clearly defined in literature, partial pressure of arterial oxygen more than 100. And regarding tissue hyperoxia, there's no specific threshold. It depends upon the perfusion to the tissues and the metabolic activity to the tissues, that is oxygen tissue, the oxygen supply and demand. So this is what is hyperoxia and how it harms the patient. It can harm the patient both at the level of the pulmonary system and at the level of the different organs. In the level of the lungs, high supplemental oxygen may abolish the hypoxic pulmonary vasoconstriction and lead to resorption atelectasis, thus hampering the gas exchange. And at the level of the systemic circulation, high oxygen levels can increase the level of reactive oxygen species, and once antioxidant is overwhelmed, this high reactive oxygen species can lead to a state of oxidative stress, both at the level of the lungs and distant organs, leading to reduction in nitric oxide and creating vasospasm, and also leading to a high level of inflammation and damage at the level of the cells, as is seen in the lungs, and at the level of the cellular structure. So seeing the effect of hyperoxia in different critically ill populations, in acute brain injury, the proposed benefit seems to be increasing the tissue brain oxygen, but the supposed harm is cerebral oxidative injury and cerebral vasospasm. Retrospective studies in acute brain injury patients, including traumatic brain injury patients and stroke, have shown that high arterial pressures of oxygen up to 300 millimeters of mercury to 400 millimeters of mercury were in fact associated with high mortality. And in fact, a randomized controlled trial in stroke patients got aborted because of high mortality in the high flow oxygen group. But still, there remains uncertainty regarding normoxemia versus targeted hyperoxemia in this group of patients, as we have dearth of randomized controlled trials. Coming to patients with cardiac arrest and acute MI, again in cardiac arrest, the risk is of cerebral oxidative injury. Besides that, there's also risk of ischemia or reperfusion injury once there's a return of spontaneous circulation and the patient is on oxygen because of reactive oxygen species. It has been found that 100% oxygen as recommended by AHA during CPR has not been assessed at lower FiO2s, and a systematic review that came up for post-cardiac arrest patients has even in fact recommended normoxemia and normocapnia in these patients. Coming to acute MI patients, a recent randomized controlled trial that came up showed that there was no benefit of giving supplemental oxygen in patients who did not have baseline hypoxemia. In ARDS patients, the hyperoxemia actually depends upon the level of gas exchange, which in turn depends upon the ARDS severity. So in one way, they are not that much exposed to the detrimental effects of hyperoxemia. But as far as the epidemiology is concerned, if you see the post-hoc analysis of lung safe study, hyperoxemia was seen in as many as 30% patients, and excess FiO2 up to 60% was being given in 2/3 of these patients. But more important point to stress is that the detrimental effects of hyperoxemia get exaggerated once the patient is not receiving lung protective ventilation, as seen in this animal study, in which high oxygen of 90% was more detrimental when when the animal was being ventilated with a high tidal volume, leading to high stretch in the lungs. As far as extracorporeal life support is concerned, is a retrospective cohort registry from ELSO, which showed that both hypoxemia and moderate hyperoxemia up to 300 millimeters of mercury were detrimental for patients with BV ECMO, and in patients going ECPR by VA ECMO, moderate hyperoxia was having a high odds of mortality. Coming to patients with sepsis, it was a randomized controlled trial, the HYPER-S2S trial that came up in 2017 by Pierre and colleagues, in which patients were divided into 4 sets. 2 sets underwent oxygen trial and other 2 sets underwent the fluid trial. In the patients that underwent the oxygen trial, 100% oxygen was given to one group to induce arterial hyperoxia, and the other group oxygen was titrated to maintain saturation from 88 to 92%. And it was found that in patients with septic shock who were on 100% oxygen, arterial hyperoxia led to high mortality and higher incidence of serious adverse events like ICU-acquired weakness and atelectasis, leading to premature termination of the trial. Coming to surgical site infections, the supposed benefit of hyperoxia is reduction of surgical site infections, but this was not seen in the proxy randomized controlled trial that came up in 2009. But however, a recent systematic review favored gently to give 80% oxygen in these patients. It was in favor of 80% oxygen, saying that there was no danger during this patient. However, this was discussed in a subsequent editorial that came up in 2019, saying that the review was the systematic review was mostly based on a single trial, the Enigma trial, which had also used 70% nitrous. Moreover, there is a large sample size required to show any effect in OT, as it is a relatively safe environment versus ICU, and the methodology regarding diagnosis of infections was also not without doubt. But to see the overall evidence in this field, in last decade, several trials and systematic reviews have come up. The first systematic review coming up in 2014, then we had the first multi-center randomized trial in 2016. Since then, several trials have come up, and in last two years, we have 4 multi-center randomized trials. So starting with the first systematic review on hyperoxia, that was basically mostly based on 17 observational studies comparing an arterial oxygen up to 300 versus an arterial oxygen between 60 to 135, showed that there was higher mortality in some critically ill subsets like post-cardiac arrest, stroke, and traumatic brain injury. Then came the first multi-center randomized trial by Rakshit Pandwar and colleagues in a small number of patients, with mainly looked at the feasibility of giving conservative oxygen therapy or not for the first time in mechanically ventilated patients, and their findings concluded that it was feasible to give conservative oxygen. The outcome was similar. Significantly large number of patients stayed at lower SpO2 during the study period in conservative oxygen group between 90 to 92% versus 95 to 99% in the high oxygen group without any difference in outcome. And so they just came out with some preliminary findings suggesting further larger randomized trials in this field. Then came the randomized controlled trial, the oxygen ICU trial by Massimo Biardis and colleagues, which was a single central trial looking at ICU mortality as a primary outcome. They found that the ICU mortality was less in the conservative oxygen group versus the conventional oxygen group. Even the secondary outcomes were better in the conservative oxygen group. Then came a systematic review, the IOTA systematic review based on 25 randomized controlled trials, which mainly had patients of stroke and MI, which found that which favored less oxygen in their patients, although there were no specific oxygenation targets, and just fixed FiO2 was used in all these studies. Then came the oxygen therapy guideline for acutely ill patients, which suggested maintaining a saturation of 90 to 94% for acute ill patients, and except those who were hypercapnic, having hypercapnic respiratory failure, and to use minimum amount of FiO2 that was necessary. But the 4 recent trials that came up in this field were either neutral or negative, and raising a question mark on conservative oxygen therapy. In 2020 came 2 trials, the ICU-ROX trial and the LOCO-2 trial. The ICU-ROX trial was done in Australia and New Zealand, and it was a multi-center randomized trial in 1,000 patients done in general ICU patients, in which conservative oxygen therapy was based on monitoring of saturation levels, SpO2, 90 to 96% versus the usual oxygen therapy group, in which there was no upper limit of SpO2 and FiO2 was kept more than 30%. The primary objective was ventilator-free days. They concluded that there was no difference between the conservative and liberal oxygen groups as regard to ventilator-free days. However, some benefit of conservative oxygen therapy was seen in patients with suspected hypoxic ischemic encephalopathy. On the other hand, the LOCO-2 trial was done mainly in ARDS patients, in which slightly lower SpO2 up to 88% was kept in the conservative oxygen therapy group, with PaO2 levels up to 55 millimeters of mercury, was compared with liberal groups SpO2 more than 96 and PO2 up to 105. They, on the other hand, found high mortality in the conservative oxygen group with high incidence of intestinal ischemia and tachyarrhythmias, raising a serious doubt on conservative oxygen therapy. However, the recent trial, the HOT ICU trial on a large number of patients that came up in 2021, including patients with hypoxemic respiratory failure with baseline PF similar to LOCO-2, in which they had kept PaO2 slightly higher than that was kept in the LOCO-2 trial, found that there was the 90-day mortality was in fact similar and there was no incidence, no difference in serious adverse events, including intestinal ischemia, unlike the LOCO-2 trial. Finally, the recent trial in this field is the trial by Jellison and H and colleagues done in multicentrically in the Netherlands, in which they included patients with SIRS, looking for the effect of hyperoxia in attenuating vasoplegia and infections. They compared the conservative oxygen up to 90 millimeters of mercury, 60 to 90 versus 105 to 135. Their primary objective was a bit different, that is SOFA rank, which looks at the trajectory of SOFA. It is non-respirative cumulative delta SOFA. And they found that SOFA rank, which looks at the organ dysfunction, was similar. Although some mild hypoxemia was more common in the COT group, but severe hypoxemia remained similar in both the groups. So to discuss why the findings were different in these trials, why earlier trials favored the conservative oxygen group and why the recent trials did not favor the conservative oxygen group, there could be some reason like how much liberal oxygen was used. Was it more liberal oxygen versus high normal oxygen? And it was not in fact that liberal. Other reasons could be a lack of uniform definition of hyperoxia. It's important to look at both the effects of oxygen percentage that has been being delivered to lungs versus the systemic effects of oxygen, that is PaO2, and not only just one metric. And FiO2 increases were allowed in all these trials for clinical reasons. So just debating on whether we have how much conservative we were. And then there was a question mark on adherence to targets as intermittent sampling was done. Then we know that there's a discrepancy between SpO2 versus PaO2 in patients with low perfusion. There are racial differences, and the sigmoid shape of SpO2 dissociation curve also. At the flat part, there can be any level of PaO2 between 60 to higher level that we do not know once we are monitoring SpO2 only. Then the blinding was also a question mark, as all the open label trials. The outcomes at per use were different, like ventilator-free day in one trial and SOFA rank on the other trial. SOFA rank was also not without any debate, because SOFA rank just compares something from the baseline. So absolute SOFA rank actually doesn't have much value. Then there can be question mark on global versus regional oxygenation monitoring in these patients at the level of the tissues. In the ventilator strategy that was used in the trials is again not without debate in terms of the lung protection that was actually being offered to these patients. Then, as we know that critical ill population is heterogeneous group, so one effect may not be replicated in the other effect. So we need to see the subgroups that were actually compared in these trials. And finally, it is possible that more critical ill patients were recruited in these trials, as the patients are more hypoxemic in LOCO-2 and hot ICU. And most of the patients in these trials had baseline hypoperfusion and shock. But some good points that we can see is non-inferiority, safety, feasibility, and logistics from the point of view of the infrastructure and cost in favor of COT, the conservative oxygen therapy group. And the meta-analysis that came up recently on 7 RCTs in which severe hypoxemia were excluded and patients were included with baseline PF more than 100 was in fact favor of conservative oxygen therapy in ICU patients. So if not hyperoxia, then is permissive hypoxemia the answer? If we borrow some information from our development, we see that mitochondrial biogenesis has in fact happened in hypoxic environment with mitochondrial pressures of oxygen less than 1 millimeters of mercury, sufficient for the respiratory chain in our body, and metabolic functions like redox reactions being segregated away from cellular DNA. So is it possible that our body can adapt to hypoxemia, as we have seen in other trials in critically ill population? So what is the group of patients in which we can resort to this therapy? So the two reviews that I've discussed, the possibility of adaptation to hypoxia, do not give any evidence in this field, although they label it as high research priority. There's some evidence, there's some suggestion that it may be used in patients who are not acutely ill, rather they are having chronic hypoxemia or sustained hypoxemia. And it's important to see the pro versus con, that is individualization, as we have seen that patients living in Tibet have a unique genetic endowment, which makes them resistant to hypoxia, and there are certain hypoxia tolerant species. So that needs to be individualized in our patients before resorting to this therapy. So to put it all together and summarize the fact, permissive hypoxemia, as of now, we cannot recommend it in our ICU patients. It needs to be in genetically acclimatized patients having tolerance to hypoxia. But as far as the recent trials tell us about the conservative oxygen therapy, we can see, say, three things: saturations between 90 to 96%, at lowest FiO2 that is possible, and at PaO2 60 to 90 millimeters of mercury, makes a CO2 therapy in ICU non-inferior and safe, with some benefit in hypoxic ischemic encephalopathy. As far as the harm is concerned, it's not been replicated in the large trial, the hot ICU trial. If you see the patients that have been included in the trial, it's better to avoid too low and too high. You see both FiO2 and SpO2, do a ABG and check PaO2 if SpO2 is doubtful, individualize the strategy to avoid it in sicker population, and most importantly, monitor the tissue oxygenation level in your patients. As far as research gap is concerned, the research gap still is at the level of the specific subgroups that may be resorted to this strategy: intermittent versus continuous hyperoxia, any time window, what is the duration of hyperoxia that is harmful. The studies in Asian population is missing, studies with medical and surgical population is missing, acute versus subacute hypoxia, we don't have larger trials, and hyperbaric versus normobaric is still we don't have larger trials, and ongoing trials may give us further answer in some of these patients, which I have mentioned here. To take home messages would be, the right question should be to how to make conservative oxygen therapy safe, and how much conservative should be kept. And as rightly said, oxygen is a drug for hypoxemia and not dyspnea. So do not give it for dyspnea, to give it for hypoxemia, and avoid precautionary high FiO2. And the right way to go would be right amount in right patient at the right time with right monitoring and a fine balance. Thank you.
Sir, you have to unmute, sir.
Yeah. Sorry. Yes. Thank you, Dr. Said, for and the possible reasons for the failure of recent RCTs, like lack of uniform definition and permissive hypoxemia, which is not recommended. So afterwards we'll have a discussion, and we'll go ahead with the Procon session, like against the use of this restricted use of oxygen, by Dr. Prabhu. Yeah, I'll invite Dr. Prabhu regarding this discussion on against this.
Hello everyone. At the outset, I thank the organizers for giving me the opportunity, and even I thank Dr. Nibble to putting some points in favor of myself. And restrictive oxygen target, I'm going to speak, it's not the way to provide oxygen therapy, especially in critically ill population. So scope of lectures will be to understand the oxygen utilization, and few points has been already put by Dr. Nibble. And the major thing is you should know your evidence, and you should read between lines. That's extremely important. And how to choose the correct patients and key message. I apologize everyone, I'm going to put too many numbers because already Nabil has given so many numbers, but of course oxygen target is nothing but a number game. So oxygen, this is a very common scenario. A patient is admitted to ICU with a community acquired pneumonia, septic shock, and acute respiratory failure, and probably the vitals are shown here. And patient is having a SpO2 of 88%, and already is ventilated with the volume control ventilation, 50% oxygen. Nurse or a junior doctor will be asking you, can I increase FiO2? Yes, of course you should. Can increase oxygen by a small fraction because they are worried because you will end up in a higher PO2. Please give oxygen. Shall I measure his PO2 because SpO2 may not be very valid when the patient is having shock? So all these questions will be asking. But only one thing I will plead is please give oxygen. Let's give oxygen and let's continue to give oxygen. With this, I start my debate. So before targeting, you should know exactly what is your limits. If you see here the oxygen dissociation curve that discussed by Dr. Nabil also, when the PO2 is 60, you will be having SpO2 of around 90. So when the PO2 drops below, there is a steep drop is there. And whenever the PO2 is more than 60, like 90, 100, then we may not know, even the SpO2 is 100, we may not know how much is the PO2. The margin of safety is much less when you compare to the margin of safety when you're giving more oxygen. Similarly, this is a very common graph everyone knows. When a patient is having shock, there is a reduced cardiac output or oxygen delivery. So the tissues try to utilize as much oxygen up to 50%, it will try to consume. But when a problem, the shock is associated with anemia or hypoxia, this is going to get confounded and the patient is going to get anaerobic threshold very early. So the lower PO2 is going to add insult and it's going to be detrimental. And this is not a rare scenario, it's very frequent in intensive care unit. Similarly, the relationship between hypoxia, hyperoxia, and normoxia is actually a U-shaped curve. So both extremes are actually decently dangerous. But the only problem is if you are actually operating at the left side near the hypoxic level, like Dr. Nabil has told, permissive hypoxia, the problem is we always deliver less than we target. To give an example, you give nutrition. So you target 2000 calories, but problem is you won't achieve. You will be finally delivering less than that. So dialysis dose, you target something, but you achieve less. Similarly, whatever you target, you are going to achieve less. And this is going to be more detrimental because you will land up in the other side. But other extreme, you don't know what is the upper limit. How safe is the upper limit? That exactly we don't know. So if you see hyperoxia, it is going to cause vasoconstriction, low blood flow, extremely important for coronary and cerebral perfusion, and reactive oxygen species, reperfusion injuries. All those may have been discussed by Dr. Nibble as well. Other side, if the patient is having hypoxia, it is going to stimulate the anaerobic metabolism. It is going to strongly stimulate the vicious cycle of cell death, and it is going to cause multi-organ failure and adverse outcomes. So here, low oxygen and hypoxia is universally detrimental to everyone. It is not that hypoxia is safe to someone. So universally it is detrimental. On the other side, if you see hyperoxia, if you want to associate with mortality, the association is extremely weak, and it's not consistent, not specific as well, and there is no temporal relationship. So like if you don't give oxygen when a patient is having a low PO2, so it is definitely going to have an adverse outcome. Similarly, you don't hear a patient that I have given more oxygen, patient died, and I given more oxygen, complication happened. So it is not so frequent, but even though we should be more cautious because a lot of observational trials, more experimental trials, animal trials are showing that giving more oxygen is a little more detrimental, but it's not for all. So my argument is the hypoxia on the one side extremely detrimental and more dangerous than actually allowing a little bit excess oxygen or mild hyperoxia, and probably within a safety range. So hypoxia, normoxia, and hyperoxia, this is the second concept actually I'm just introducing. So extremely important. So here if you see that the PO2 that is less than 55, definitely know the hypoxia is there. But on the other hand, we don't know how much excess is excess, and there is no solid cutoff. Retrospective studies, they have mainly shown that more than 120 as showing some adverse outcome, and it's logical to use more than 100. For example, in patient who don't have any oxygen requirement, like healthy people, usually they may not have a PO2 more than 100. Usually it will be less than 90, commonly around 70. Unless you give oxygen, you may not reach PO2 more than 100. Probably it could be a logical cutoff. Lot of studies that are tried with the liberal therapy, they even use less than 80 as a higher levels, but still we exactly don't know. The studies, whatever we are going to see, they have a lot of overlap because of a varied cutoff, because we don't exactly what you are comparing. This is extremely important. We are not clear what are we comparing with. What is hypoxia, normoxia, hyperoxia, we don't know. Many studies are heterogeneous. They are comparing different levels. One study, if PO2 90 is hyperoxia, one study it is a conservative range. So a lot of overlap is there. So third concept is let's give more oxygen. I will try to explain. This is extremely important study is observational data from a very large database. Almost everyone is aware of a mimic database as well as EICU database. This is actually database from US, actually collected from all electronic and case record forms as well as ECRs. So here they try to find what could be the optimal oxygen target. Here if you see that extreme left, the U-shaped curve, it is more steeper when it is in hypoxic site, less than 94%. If you see, it is more steeper. Similarly, in the other side, actually, if you see, the steepness is much less. Here, if you see, it is more of a flat area rather than a more steep area here. So other side, if you see ICU mortality compared to hospital mortality, again, it is very high when your oxygenation is less than 94%. Probably they are giving a good actually information that optimal target is actually between 94 and 98. That could be the operative safe area. Similarly, how much time exactly you are maintaining your oxygenation in a target range, that is 94 to 98, they have studied. Here, if you see that when you are maintaining the oxygen saturation more than 80%, your mortality is much lesser compared to less than 40%. Similarly, if you see here, when you are having a oxygen saturation below 94, if you're spending more than long time, you can see that the mortality increases drastically. So when you're maintaining oxygenation much lesser, your mortality is very high, and if you're maintaining a decent range, the mortality is much less. This is a good study, even though retrospective, it is a hypothesis generating study. So second, hyperoxemia in post-surgical patients, and Dr. Neeraj is going to deal with it in great detail. I'm going to give a snapshot. It is nothing but a prospective study, secondary analysis, post-surgical patients with a septic shock. And the PO2 less than 100, more than 100, there's a cutoff we had taken, and 90-day mortality was the primary outcome. Here, if you see that whenever the PO2 is much higher, so the outcome is actually very bad. For example, when the PO2 is actually is more than 100, if you see here, the probability of actually death is different. So the length of stay is high, ventilated days is high, organ dysfunction days is high, when actually if you are dealing with a PO2 less than 100. So that means if you give more oxygen, probably you are a beneficial range rather than giving less oxygen. So less oxygen is more detrimental to post-surgical patients, especially with increased hospital-acquired infections, wound adhesions, and a lot of post-surgical complications. Second study is a ICU rock study, and already we are aware of it. So it is one of the largest trial in this field, 1,000 patients from Australia. So conventional therapy or conservative, so they strictly maintain less than 97% SpO2, and usual therapy, there is no exact cutoff. Usual means your unit usual could be different from other unit, but they felt that usual means they are going to give more oxygen. That may not be always. Primary outcome is soft endpoint, ventilator free days. Here, if you see that there is no difference between two groups. So here, if you exactly see what exactly they got after giving oxygen, the first one is the A diagram showing the mean PO2 level for first 10 days. If you see the conservative arm, that is a blue color line, it is almost touching 80 versus your usual arm, that is around 90-95. So exactly this study, even though they compare between 80 and 95, 80 and 95 seems to be in a normal range, but actually it is not showing. So if you compare like versus like, the outcome is going to be same. So similarly, B and C is showing you the range of PO2, lower and higher. If you see the PO2, the lower range conservative is between 70 to 100. Even though 100, we feel that it is little on hyperoxemic side, the study actually this is taken as a conservative. And if you see the other side, hyperoxemia side, if you see, it is 80 to 110. So there is a quite a bit of overlap is there. And the question is, the whatever the outcome, primary or secondary, there is no difference. Here, even though you actually maintain and finally got a PO2 in a liberal side, 80 to 110, slightly higher than what we actually debating, but nothing harm is found. Where is the harm? The study is shown. Even though the efficacy is equal, there is no harm shown in this study. So similarly, the ICU rock, this is a post-hoc analysis, separate trial, especially for a sepsis patient. 251 patients, all mechanically ventilated. Here, if you see that the PO2 achieved is between 80 to almost 95. And here exactly, if you see, there is a higher trend of mortality in ICU as well as 90-day mortality in the conservative arm, and with the adjusted odds ratio, adjusted for age, gender, and trial site as well as severity, Apache. You see that there is a 30% to 60% increased mortality in the conservative arm, especially in the patients with sepsis. Even though it is a very common, when a patient is coming in sepsis and septic shock, usually we try to achieve the normal perfusion by providing more fluids, vasopressor, and oxygen. So definitely giving a lesser oxygen in a patient with sepsis is going to be more detrimental, as shown in this good study. So even though it is a post-hoc analysis, it's not powered, we should take this as a pinch of salt, but definitely there is a signal that is favoring the usual oxygen. So another good trial, that trial has been shown by Dr. Neville also, in ARDS and LOCO-2 trial. And the hypothesis is, if you give conservative therapy, it should reduce mortality. That was their hypothesis. Here they are compared between 55 to 70 in the conservative side, versus 90 to 105 in a liberal side. And if you see here, there is a extremely good separation between two arms is there. If you see that separation extremely good. So here the mean PO2 achieved in a conservative side is nearly 70. Other way, you are almost achieved 105. So it is like comparing 70 versus 105. If you see that liberal oxygen group, actually it has a very good survival. And the survival is much higher in the liberal oxygen group. The study was stopped in between because there was a lot of complication that is found with the conservative trial. There was a 5 cases of mesenteric ischemia that was not explained by anything. So the without interim analysis, the study was stopped with the ethical committee. So it is definitely showing that if you are giving oxygen in the conservative side, there is a definitely signal of increased harm and compared to little bit in a liberal side. Here, even though you are actually liberal side, it is nearly around 105. It has not proven any harm, but in other ways, it has proven harm in the conservative arm. So this is a good trial, heart ICU trial. That is a recent trial with almost every century in Europe, with many countries across. So the population they studied is acute hypoxemic respiratory failure, and lower PO2 should reduce mortality, around 3,000 patients. Here the trial is good enough that they compared the PO2 60 versus 90, and they continued this range up to 90 days. Almost 90 days they maintain the PO2. Extremely difficult to do, and they have done beautifully. So here, if you see that exactly the PO2 they compared is between 70 versus 93. So this is a median PO2, and they didn't find any mortality. So again, the conservative as well as liberal, according to them, 60 versus 90 was about to study, but actually they land up in studying 70 versus 93, equally beneficial. Again, there is no harm proven. So here, what I'm trying to tell is, even though studies are neutral, it doesn't mean that one arm is bad than other. They may be equally beneficial, but we may not know. Secondary analysis, post hoc, something may come with some harm. That's why actually other studies will start. So here, the long-term mortality and quality of life, the same trial, they pre-planned it 1 year before itself. And after 1 year, what you have studied is health-related quality of life, as well as the 1 year mortality. So there is no difference again. So whatever the oxygen you maintain for even the 90 days, so there is no difference between quality of life as well as mortality. So the second point I'm trying to prove in terms of a conservative versus liberal is, initially I had shown studies, even though they are equal, there is no harm proven. So when both intervention are equal, one thing is they are equally beneficial. There is some harm can be shown in one trial, or is equally beneficial and no harm. This is how actually we are. So whatever liberal conservative, they're equal, but no harm shown. So don't go by the conclusion of the study. It may completely take away from the important gist of information, but you should read between lines. That is extremely important, and you have to choose wisely the patients. Let me tell you. So this is the important meta-analysis, and it has been debated many times. Liberal versus conservative oxygen therapy in acutely ill patients. Up to 2017, they have taken all patients. You can see the patient number is 16,000. A lot of good number of patients are there, and it taken only the randomized control trial. So 25 RCTs has been included. So primary outcome was 30-day mortality. Secondary was hospital infections, length of stay, etc., etc. Here, if you see that the conservative oxygen therapy is actually having a good survival compared to the liberal one. But if you see in between lines, if you see here, out of all studies, there are only 2 critically ill studies are there that related to critical illness. There is one study by Gerardis, that is from Italy. That study actually it was stopped before, and PANVAR is nothing but a feasibility trial. So there was no outcome compared. It is feasible, whether to feasible to do conservative or not. That was the trial. If you see here, the 32% of weightage, actually it is coming from one study. So that study has a lot of bias, and there is a lot of reporting bias, and the study was not blinded at all. So it's a poor quality study. So this is the one actually it is taking the diamond away from more oxygen. It is showing less oxygen is favorable. Other study, if you see, it is stroke and patient with emergency surgery and myocardial infarction. All are non-critically ill patients. If you take this study acutely ill, but they are not critically ill, and the study that is having very poor quality contributing 32%, you have to take the result with a pinch of salt. If you remove that study, then probably it will be equal. So the same study, there is no disability. And if you see that hospital-acquired infections in a patient who is having a medical reason for admission, there is no difference. But especially when the patient is admitted for after a surgery, there is a reduced infection rate, especially if you give more oxygen. This is an important take-home message from this trial. So one more systemic review and meta-analysis that included the large trial that show you heart ICU as well as the ICU rocks trial. If you see here the other trials, the trial that I already show you that poor quality, that is oxygen ICU trial. This is Gria's trial that has been stopped because of complications. Because it is stopped much early, the effect size could be much higher. So it had shown that it is having some mortality benefit with conservative therapy, but that is not. If you see here, the arms between different studies. So initially the studies that has been done before, actually they compared with very high amount of oxygen. So if you see here, almost 100% is given for 24 hours that we never practice nowadays. And if it is just kept constant for 80%, that also we never practice. So if you give extremely high oxygen to one group and you prove that conservative trial is better, then that's not correct. So the recent trial, they are a little more clever. They are choosing a more logical cutoff depending upon how we practice. If you see that line, that is actually I have taken because the largest trial out of this is the heart ICU trial that consists almost 3,000 patients. They compared 60 versus 90 PO2. If you put a line between, then you can see that many trials there is a overlap is there. For some trial, the PO2 between 70-100 is conservative, but some other trial, that same thing is coming in liberal. So this is the major problem. So other trial, that hyper 2S trial is 2x2 factorial trial. They given excess oxygen 100% for first 24 hours. They given hypertonic saline in sepsis patients. Even though there is some signal towards conservative therapy, so the way they were given 100% oxygen, that is not the way actually we practice now. So here, if you see, there is a division between normoxia and hypoxia and hypoxia and normoxia, because with so much of heterogeneity, with so much overlap, it's very difficult to compare. So the authors, they have divided the group into two. One is normoxia versus hyperoxia, and other is hypoxemia versus normoxia. If you see that hyperoxemia group, that is the second one. So the diamond is almost neutral. There is no difference between both groups here. But here, if you see that there is a favor towards less oxygen, that is actually confounded by this one trial. That is nothing but the trial I will show you, that's very poor quality, Gria's trial that is stopped in between. So if you show that quality, if you see here, the trial is not blinded. It is open label trial. The blinding of outcome also is not there. And the more important is the incomplete outcome. So the data that is actually, it's been given a lot of biases there. Apart from that selection bias, so many biases there. If you take this study, then probably actually we are actually confounding. So the heterogeneity is much higher. Highly biased trials are there, and it's going to give a low quality evidence. So here, if you remove the trial, again the diamond is going to be neutral. It is not going to favor either side. So heart ICU trial, they did one basic analysis because they want to take out all these heterogeneities in providing oxygen. So this is a good trial and very concept based, and different groups have been compared. If you see here, the lower oxygen target was unlikely to affect the overall mortality among critically ill patients in hypoxic respiratory failure patients. Interestingly, if you see a patient who had a shock with increasing noradrenaline dose, grade 1, if you see, the probability of death is actually more. So if you see that the green one is the one that actually having a more oxygen, and the blue one is the one they deliver lesser oxygen. So if you deliver less oxygen in a patient with a shock, that too in the shock dose is very high, NORAD dose increasing, that means the mortality is very high. So the non-epinephrine dose and death when less oxygen is supplied, but even though actually it requires a further evaluation because this was not the primary outcome study, this was the further analysis from this study. But this is opening up a good area of research where actually we have to see when a patient with shock and without shock. But definitely there is a signal that when a patient is having a shock, if you give low oxygen, that is going to be detrimental. So conservative oxygen in hypoxic injury, this is the only area where if you give lesser oxygen compared to little higher oxygen is beneficial. So in this study is a post-hoc analysis of a ICU rock trial. What they have proven is almost all primary as well as secondary objective was more favored towards conservative, because we know that patients having hypoxic injury, providing excess oxygen may lead to a lot of free radical formation and damage. It is hypothetical also is decently good enough, and the concept is good, and the study has proven. This is the only one area where lesser oxygen may be more beneficial, but still you should be taken as a pinch of salt because it is a post-hoc analysis. So let's put it together. So if we see all trials, actually they have found with the different results, but inclusion criteria, that means patient being studied more are acute respiratory failure, number one. Second, they are studied with a patient with sepsis of different etiologies. Third, patients with a post-surgery with sepsis. And fourth is hypoxic injury and pulmonary toxicities. Even I have gone through a rounds today morning, almost nearly a floor with 30 patients. I have seen that how many patients are actually having respiratory failure as well as sepsis. Almost more than 50 to 60 patients are having either acute respiratory failure or ventilator or having shock. Almost it is reflecting the real life scenario. If you want to put all these things together, I'm dividing the oxygen into different levels based on what we got the level from randomized trial rather than from the observational studies. If you see that here, the one that is shown the in brackets are nothing but PO2. If you're given a blue color, that means these are the studies that are not shown either harm or benefit. They are equal to conservative therapy. But here, if you see that 90 PO2, 110 PO2, still it's not shown any harm. Other thing is the green color, what I put is these studies have shown definite benefit when you're giving a little higher oxygen, that is 90 and 105 in ARDS in sepsis patients. And a lot of meta-analysis is that they have shown some kind of a benefit with a little higher oxygen. And post-op sepsis already have shown in the meta-analysis as well as one more trial I have shown higher oxygen was more beneficial. Here, rather than proving that both are equal, I have shown data that giving little excess oxygen is more beneficial in this population. Contradictory other side, if you see that except a hypoxic ischemic encephalopathy, there is no major trial that has shown benefit if you are in a slightly on a lesser side of oxygen. And myocardial infarction, they are not a critically ill patients, but patients who are coming with MI and they don't have hypoxia, you give oxygen and you don't give oxygen. They have seen that if you give oxygen when patient doesn't require, that has proven more adverse event. That is not going to be a good practice. When patient doesn't require oxygen, you give it. So they are in critically, not in critically ill patients. So I'm not dealing in detail. So what are the trials that has proven harm? If you see that ARDS trial I showed you, lesser oxygen, more mesenteric ischemia, the trial was stopped actually because of adverse outcomes. Other trial, Oxy ICU trial, that is a trial that I keep on telling you, the trial with a lot of flaws and bias, that Giriardis trial from Italy. So that has shown that higher oxygen was little not favoring the outcomes. So similarly, if you want to put all these diagnoses to according to the PO2 group, if you see maximum diagnosis comes here, that means patient with acute respiratory failure, that is from ICU rocks trial as well as hot ICU, patient with sepsis, any kind of sepsis source, and postoperative surgical sepsis, and patient is having a hospital-acquired infection and some brain pathologies except hypoxic ischemia, like a stroke and a meningitis. This kind of population almost coming towards a little excess oxygen group where they proven benefit. Other side, patient post cardiac arrest and maybe MI patients, maybe because of reperfusion, like a reperfusion injury because of reactive oxygen species. They have proven that if you give a little more oxygen, maybe detriment in this group. So here exactly you are getting more population still coming towards little excess oxygen group, little more oxygen. But other extremes, we exactly don't know what population is going to benefit. And studies have not done in this area. So better if you want to target or choose a patient, so better not to choose PO2 less than 60 as a target or more than 110, because these areas has not been tested, not been studied. So the green area, the zone, it is
moving out of time.
60 to 80 is little towards a conservative side, and 80 to 110 is more towards a liberal side. If you see this data, what I have shown you, So maximum patients who are actually we are dealing day-to-day practice, they are coming down in the 80 to 110 level, because these are things studies have shown. The last point, conservative versus liberal, how I'm going to conclude. So if you see conceptually, what is the advantage of providing and not providing oxygen? Definitely hypoxia kills. It is a fire. Hypoxia is single agent that can kill. But excess oxygen may be dangerous. Just giving excess oxygen is not going to directly kill, but it may aggravate the problem. Like patients having brain injury, give more oxygen, patient goes for a little more secondary brain damage and causes problem like that. So if you see here, I'm going to give a little green thumb here for conceptual, because hypoxia is definitely towards a higher mortality, and that is decently proven. Second point, whatever study they are showing, it should be feasible to do. Is it feasible to titrate oxygen towards lower side? Yes, studies have proven. That is one trial by Panwar. Study shown that it is easy to titrate. It is feasible. And titrating little higher side is too easy compared to titrating a lesser side. But remember, we deliver less oxygen when we target is on lower side. But both are almost equal. If you see benefits, so either giving little excess oxygen or little lower oxygen is going to be beneficial. So lower oxygen in a very small population is proven beneficial. To give example, patient with MI and patient is having a hypoxic brain damage. But other side, we are having a decently good population, either post-hoc analysis or directly in a randomized control trial, they have proven benefit. So it's a big yes. So other side, I'm going to be a little more neutral. Is there any harm that is proven in randomized trial? That should be a good quality evidence. So the potentially it's harmful. The margin of safety is much lesser in hypoxemic side. But yes, definitely hyperoxia, it's more detrimental, but a lot of information is from observational data. None of the randomized trial, they have proven that hyperoxia is much worrisome, except a hyper-2S trial. That is a 2x2 trial. That is maybe because of sepsis, or maybe you are giving a hypertonic saline, a lot of confounders were there. So current data, it is as safe as conservative. If I'm going to take a cutoff of 80 to 110, it is as safe as giving a lesser oxygen. So probably I can keep it a little more neutral rather than overzealously telling that yes, giving more oxygen is beneficial, but definitely giving less oxygen is going to be potentially harmful. I given a yellow color because I want to maintain the neutrality, but as well as a inverted thumb because the margin of safety is much less. Is it going to be cost effective? Yes, if you're going to give lesser oxygen and less utilization, cost is going to be lesser in conservative side, but may not be in a liberal side. But when you're going to prevent complication, it's worth giving little excess oxygen. So similarly, what is the evidence that if favoring any superiority? There is no major superiority, but with a pinch of salt, we can take it yes, especially in a sepsis, patient with shock, post-operative, and a patient having acute respiratory failure. There is upper limit of safety is still debatable, but still studies have shown that up to 110 decently is okay enough. Here, exactly if you see a lot of green thumbs for liberal side. So putting together, if you want to just keep a cutoff, are restrictive is equal to conservative? Are you going to call usual is nothing but conventional? It is nothing but liberal. Are you going to equate each other? With studies that have shown so much of crossing as well as overlap, and you are actually almost in a midline where this side if you jump you will be more hypoxic and it's more a steep deadly area. Other side if you jump it is going to be a little more hypoxia, but I feel that hypoxia is not going to be detrimental immediately. It may have a long-term effect and not been completely proven. So depending upon data that I'll show you, and more patients decently good enough to maintain PO to around 80 to 100, that is proven from randomized trials, I'm going to call myself cautiously liberal. Rather than I'm being too liberal or generous, I'm cautious. I'm going to call myself as cautiously liberal. And if I want to summarize, hypoxia definitely kills. Hyperoxia is dangerous. Yes, please judge both and give oxygen. There is no solid cutoff till now. There is general no harm proven with little more oxygen, and you have to individualize your oxygen target. So decently good enough to give slightly excess oxygen in a respiratory failure, sepsis, and post-surgical patient, especially with shock. Let's give little more oxygen and work in a safe zone. Join the cautious liberal group, and thank you very much.
Thank you, Dr. Prabhu, for presenting the evidence in which shows that maintaining hyperoxemia is not harmful and equally effective. And just thank you for being a cautiously liberal in case of usage of oxygen. So because as we are moving out of time, we are having for 3 to 5 minutes for rebuttal. Dr. Said Nibil, can we have 3 to 5 minutes for rebuttal?
Yeah, I would say that it's better to be on the normal side rather than being either too low or too high. And still, we do not know what is the cutoff for liberal, or how liberal we should be, and maybe the right bit would be somewhere in between. And it's better to correlate with partial pressure of oxygen whenever we have doubt with SpO2, as is often seen in critical patients. And rather than being too conservative or too liberal, it should be the moderate way, as Dr. Matesh has also said, and choosing our patients and individualizing the strategy.
Yeah, because most of the trials are saying no difference between the hyperoxemia and normoxemia, and few saying that hyperoxemia is harmful, like avoid study. So we can safely agree almost no patient needs more than 300 millimeters of oxygen. And because we are lacking the optimal levels, because the optimal partial pressure for oxygen probably depends upon multifactorial. It depends upon the disease status as well as its severity, and it depends upon the organ functions as well as its tissue oxygenation and the state of microcirculation, and also on the depends upon the metabolic supply as well as demand, and also on the comorbidities as well as so on. So because we all know that one size doesn't fit all, and as of now we are not having what is the optimum and best level for oxygenation. So we do know that very low levels, that is less than PO2 of 60 millimeters of mercury and SpO2 of less than 88 to 90, potentially harmful, and it should be avoided. So, and presently we don't know what is the upper limit which is causing harm, or because most of there is no marker for oxygen toxicity, as well as the studies have shown different levels of usage. So because a lot of studies have shown that hyperoxia is detrimental in case of ischemic neurological state, myocardial infarction, and hypoxic ischemic encephalopathy. And this cannot be said for the TBI because optimal levels in the sepsis and trauma are not known. So we should know the optimal levels and duration of benefits to be established. So we need to identify how to approach and how to improve the oxygen delivery without increasing the oxidative stress or oxidative injury. So we have to remember once again that oxygen is a drug with narrow therapeutic index, and we have to use it diligently. So, and personalized oxygen therapy is on its way. So I think we can have better answers when we come through this Mega Rocks trial, which is a LOR and 6 trial with robust and innovative designs, where power has been calculated for individual subgroups such as acute brain injury and as well as sepsis. This trial should give us an answer. Then till then, we can manage that PO2 range between 70 to 100 is probably reasonable with a SpO2 of around 92 to 96. It's open to discussion. Dr. Hemant? Any questions?
Hi.
Yes.
No,
hi.
no. It's just that, first of all, we need to address what is restrictive and what is liberal when we design a study. And that's where we are faltering.
Yes.
And many times, in order to create two groups, we create artificial groups with, a large, a difference, something like, 6 ml versus 12 ml per kg tidal volume. Even in those days, nobody used to use 12 ml per kg tidal volume. So obviously, we need to be a bit more practical when we design a study. And as most of the speakers have told, we can't put all subgroups together because different set of patients' requirements will be different, number one, and number two, at what part of the disease trajectory they are in, that also matters. Whether whether day 2 or day 3, we all were in COVID, we knew that third week they were happy with 85, 88 saturation. So as you rightly said, we have to look forward and create subgroups more diligently. Thank you.
If there are no questions, we can move on for the general club. Yeah. Can we? Yeah, if there are no questions, we are going to move on for the next session of Journal Club. Thank you, Dr. Saeed, as well as thank you, Dr. Prabhu, for creating an interesting and excellent environment regarding this topic of restricted usage of oxygen in the critically ill patient.
Thank you, sir.
Yeah, we are moving for the next session regarding the Journal Club. Now we are having a younger intensivist, fellow in critical care, DM final year from NRM Medical College, Dr. Neeraj Guttikonda. He is going to talk about this regarding the Journal Club, hyperoxemia in post-surgical sepsis and septic shock patient, which is associated with the reduced mortality. Yes, it's over to you, Dr. Neeraj.
Thank you, sir. Good evening, everyone. I would first like to thank all the organizers and my HOD RF sir for giving me this opportunity. Today, my topic, it's a journal titled Hyperoxemia in post-surgical sepsis and septic shock patients is associated with reduced mortality. So before going to the journal, we'll go through some introduction slides, which has already been discussed by the previous Procon session. So coming to the introduction, we already know that how double sword character the oxygen molecule has. It's already well established, and matter of debates. It is a matter of debate since its discovery at the end of 18th century. So oxygen plays a crucial role during ATP synthesis because lack of oxygen lead to anaerobic metabolism and decreased ATP production and increased lactate production. And other chemical characteristics, it has a strong oxidizing property capable of damaging any biological molecule. That is defining the paradigm of oxygen toxicity. And so what is oxygen toxicity? So coming to the oxygen toxicity, this phenomenon is due to the formation of reactive oxygen species. So the magnitude directly correlated to the level of partial pressure of oxygen, and deleterious side effects, especially in conditions of ischemic perfusion injuries such as hypoxemic ischemic encephalopathy, and also in conditions of myocardial infarction. It has its deleterious effects leading to formation of reactive oxygen species and causing apoptotic cell death. And the more pronounced oxygen toxicity is seen when given on a long-term duration, that is beyond at least beyond 12 to 24-hour duration. So more is the duration, more is the intensity of oxygen toxicity. So in this, how is this coming to a basic physiology? How is this pre-oxygen radicals produced? So in the normal physiological phenomenon, in the respiratory chain, in the mitochondria, during electron transport chains of oxygen is transformed into H2O, some amount of oxygen usually gets leaked from the electron transport chain, leading to formation of reactive oxygen species. These reactive oxygen species is physiological generally. So against this, there is always a production of antioxidants. Antioxidants such as endogenous antioxidants such as superoxide dismutase and glutathione peroxidase. This will combat these reactive oxygen species and maintain a balanced state, that is the redox state. So when these oxygen supply is increased, there is increased production of reactive oxygen species, and there will be a imbalance between oxidants and the antioxidants. So because of increase of increase of oxidants in hyperoxic conditions, there will be leading to deleterious effects such as apoptotic cell death. There are multiple mechanisms which lead to this death by reactive oxygen species. These are reactive oxygen species exert harmful effects on biological structures by multiple mechanisms, such as damaging DNA or RNA, impairing DNA repair systems, and affecting transcription or by lipid peroxidation, and interfere with protein function by direct oxidation of amino acids. So what are these antioxidants? We all know endogenous, I already discussed, the exogenous such as vitamin C and vitamin E, that is vitamin C, ascorbic acid. All these antioxidants help us to scavenge these reactive oxygen species and also prevent the formation of ROS as well in the mitochondria. And the exposure time and PO2 ultimately determine the cumulative oxygen dose. So these are the physiological variables. These are the physiological characteristics of hyperoxia. It has positive characters as well as negative characters. The green ones are the positive outcomes, and the red ones are the negative outcomes of this high oxygen. And so what is the positive outcomes is helps you to increase diffusion of oxygen and also helps to increase MAP by decreasing the nitrous oxide, nitric oxide, and also decreases inflammation. And reactive oxygen species also has this host defense mechanism. It helps us, it has bactericidal qualities. It helps to kill the bacteria and viruses. And when there is imbalance, when there is excess of ROS, it will have its deleterious effects. And in coming to the negative qualities, it's been already discussed. Inhibition of HPV, hypoxypulmonary vasoconstriction, and leading to and also resorption atelectasis, leading to decreased pulmonary gas exchange. And leading to this hyperoxia also lead to inflammation and increased reactive oxygen species. Oxidative and nitrocytic stress is increased. And finally, reactive oxygen species increase leads to uncoupling of the mitochondrial respiration as well. So what are the clinical applications of hyperoxemia? We have 2-3 applications generally. Carbon monoxide intoxication, where carbon monoxide toxicity is mainly due to the blockage of complex 4 of mitochondrial respiratory chain, that is cytochrome C oxidase. So inhibition of this mitochondrial respiration will result in oxidative and nitrocytic stress. So higher oxygen concentration will restore normal electron transport within the respiratory chain and thereby decreasing this radical production. So the half-life of CO elimination is inversely related to the arterial PO2s. So coming to gas embolism DCI, it also has another advantage with hyperoxia, because in negative decompression injuries, there will be bubble formation, intravascular, extravascular, because of the inert gas of nitrogen. When oxygen is supplied, because of diffusion, the size of the molecule, size of the bubble will be decreased. So N2 component in the bubble will be decreased, thereby revascularization, causing revascularization and decreasing its effects. And there are multiple trials which have already been discussed by previous speakers. That is oxygen ICU trial, Hyper S2 trial, Avoid trial, Detox 2 MI trial. These were done on different cohort of patients. That is in septic shock patients, acute MI patients, acute coronary syndrome patients, traumatic brain injury and stroke patients, and even on cardiac arrest patients. So coming to the oxygen ICU trial, it's a single-centered RCT conducted in between March 2010 to 2012. There they have they have stratified it into conservative and standard oxygen therapy. Target SpO2 was 94 to 98% in the conservative group, and in the standard group it was 97 to 100%. So the target at a higher level. So conclusion and relevance of the study was among critically ill patients with an ICU length of stay of 72 hours or longer, a conservative protocol resulted in the lower ICU mortality. So here the conservative protocol has resulted in lower ICU mortality, and the Hyper-S2 trial. In this also the conclusion was it was done in septic shock patients. Setting FiO2 to 1 to induce arterial hypoxia might increase the risk of mortality. Again, higher oxygen levels will lead to increase in the mortality from this trial also. And Avoid trial, air versus oxygen in S2 segment elevated MI. In this also, in conditions of myocardial ischemia, infarction, when oxygen supply is being given in non-hypoxemic patients, this has resulted in increase of myocardial infarct size assessed at 6 months by the evidence of biomarkers. So unnecessary oxygen supplementation without in a patient, in a non-hypoxemic patients, resulted in increase of myocardial infarct size in these patients as well. That was the outcome of Avoid trial. And SO2S trial, it was done in stroke patients, stroke oxygen study, a multi-centered study. The conclusion of this was among non-hypoxemic patients with acute stroke, the prophylactic use of low-dose oxygen supplementation did not reduce death or disability at 3 months. Even unnecessary or prophylactic supplementation of oxygen in these patients also did not produce any change, did not cause any improvement in death or disability at 3 months. This is also a single-centered RCT. Coming to the hot ICU trial, in acute hypoxemic respiratory failure, does a lower versus higher oxygen target reduce mortality was a clinical question. So primary outcome, there were 2 groups, the low target group and the higher oxygen target group, with PO2 of 60 to PO2 of 90. 90 was a higher target group, but the primary outcome, 90-day all-cause mortality, no significant difference was found. And in secondary outcomes also, there was no significant difference in even from the hot ICU trial. So this was these trials have already been discussed, but I'm giving just a brief outline of these trials. This is a systemic review and meta-analysis which was done. Their clinical question was, does a liberal oxygen strategy compared with conservative oxygen strategy increase hospital mortality? So it included 25 RCTs, which included around 16,000 patients. So the conclusion of this systemic analysis was analysis provides evidence that hyperoxemia caused by liberal oxygen strategy increases mortality. The final outcome of this study was liberal oxygen strategy has increased mortality. So this is meta-analysis of perioperative hyperoxia for surgical site infections in patients with general surgery. So it included 9 RCTs and which included 3,281 patients. They maintained saturation of 80% versus 30%. The final outcome of this study was perioperative hyperoxia did not reduce surgical site infection in patients with general surgery. But the subgroup analysis which was done has shown that in patients with colorectal surgery who were given intraoperative plus postoperative 6-hours oxygen inhalation had decreased surgical site infections. So this was the outcome in subgroup analysis in surgical patients. Now coming to our journal, that is hyperoxemia and post-surgical, this topic of debate today. Hyperoxemia and post-surgical sepsis and septic shock patients is associated with reduced mortality. It was done by Martin Fernandez et al. It was published in Critical Care Journal in Jan 2022. Coming to the design of this study, it is a prospective observational study. It included a cohort of 454 adult patients who were admitted in surgical ICU in Spain, in a 700-bed hospital in Spain. Study period was between December 2006 to February 2017. So the aim of the study was evaluate the effect of 90-day mortality of the conservative versus standard oxygen therapy administered during the first 48 hours after the onset of sepsis and septic shock. So the primary endpoint was 90-day mortality after diagnosis of sepsis, and secondary endpoint was ICU length of stay and time to extubation. So the inclusion criteria in the study were already it's an adult group, so it is more than 18 years of age and who has underwent major surgery and admitted to surgical ICU, and diagnosis of sepsis or septic shock according to sepsis 3 definitions. So need for invasive mechanical ventilation. So exclusion criteria were patients meeting clinical criteria of sepsis and septic shock with the negative microbiological studies. These patients were excluded, and this study has included the sepsis 3 guidelines, not the latest guidelines, because this study was done between 2006 and 2017. So it is completely based on sepsis 3 guidelines. Coming to the methodology, they have stratified the patients into 2 groups, hyperoxemia group and normoxemia group. Hyperoxemia group included patients with PO2 of more than 100, and normoxemia group was included patients with PO2 of less than 100. So what is how did they stratified? The patients admitted in the ICU was screened daily on for the onset of severe sepsis or septic shock, and they used a standardized form for collecting demographical and as well as clinical data in the first 24 hours after diagnosis of sepsis or septic shock. And severity of illness was assessed using SOFA and Apache 2 scores. So sepsis and septic shock were diagnosed according to the sepsis 3 criteria, and patients were also managed as per the sepsis 3 guidelines. So here the baseline characteristics you can observe are the first group, that is a PO2 of more than less than 100 group, and the second group is PO2 of more than 100. So in the PO2 of less than 100, there were more number of cardiovascular disease patients as well as chronic respiratory disease patients and obesity patients. There were 34.9% of CAD patients, and chronic respiratory disease were also more in number in the hypoxia group, that is normoxia group, that is PO2 of less than 100, it's 22.3%. And in obesity also 18.5% of the individuals are present in the normoxia group, PO2 less than 100. And respiratory tract infections were also on the higher number in this PO2 of less than 100 group compared to the PO2 of more than 100 group, which showed a mortality benefit. And other significant difference was PF ratios, that is in the PO2 of less than 100 group, the PF ratios of 157, which indicates that it is a moderate ARDS. And in the patients with the hyperoxia group, that is PO2 of more than 100, where PF ratio was 278. It's it shows a mild ARDS patients. And also in this study, they have shown that FiO2, a fixed FiO2 of 0.50 was given to both the patients, both the group of the patients. Other parameters have been described here. So these are the characteristics which are significant differentiation in differences between the 2 groups. And the results of this study were the primary outcome, the mortality at 90 days was significantly lower in the PO2 of more than 100 group. And mortality was significantly higher side on the PO2 of less than 100 group, that is 37 versus 25.5%. and the length of ICU stay and number of days of mechanical ventilation also had a significant difference, which was towards PO2 of more than 100 group. It was lesser in PO2 of more than 100 groups, 100 group. So this is a Kaplan-Meier analysis. Here the survival percentage of survival was this x-axis shows the time duration of days. That is, we are checking the 90-day mortality, and the percentage of survival is defined on the shown on the y-axis. So here this is the dotted line with the PO2 of more than 100 and the normal line with PO2 of less than 100. A dotted line with PO2 of more than 100 shows a lesser mortality around 0.8, and with the straight line of PO2 of more than straight line with PO2 of less than 100 shows lesser survival percentage, which has already been shown. So Kaplan-Meier representation is being given here, and so what they have done is, because there were multiple variables that are showing a characteristic difference in the baseline characteristic which you have discussed, they have done a multivariate analysis to check out for the confounding, how much it is confounding for this final outcome of mortality. So even after checking, doing a multivariate analysis, they found out that PO2 more than 100 group has a significantly lower mortality with a odds ratio of 0.54 and a significant p-value 0.009. Even they have given a final conclusion that they have excluded PO2 of less than 60 group, and they have checked for them. They have done a multivariate analysis to check out for the confounding factors which could also contribute to the mortality. Even after doing this, they have confirmed that the PO2 of more than 100 group has a mortality advantage between the two groups. And this is the graph Dr. Natesh sir has already shown. In this probability of death is being shown because in the more hypoxia group, the probability of death is higher. Here the probability of death is higher in the more hypoxia group when at 100 to 200 there was a stable probability of death. At after 200 again the probability of death has further gone down. But so in hyperoxia group the probability of death is lower, and the hypoxia group the probability of death is higher as per this graph in this study. So the primary outcome, patients with PO2 of more than 100 millimeters of mercury had lower 90-day mortality, and also the secondary outcome, reduced length of ICU stay, a significant difference was there, and shorter duration of mechanical ventilation was there, which was also significant in the PO2 of more than 100 group. So final conclusion of the study, oxygenation with PO2 above 100 millimeters of mercury was independently associated with lower 90-day mortality, shorter ICU stay, and intubation time in critically ill post-surgical sepsis and septic shock patients. So what are the drawbacks of this study? So we already seen the basic baseline characteristic drawbacks. PO2 of less than 100 group as higher Apache 2 score patients, and the chronic respiratory disease patients were there, and obesity patients and respiratory tract infection patients were there. So even though they have done a multivariate analysis to check for the confounding, but they have not included all these criteria into the multivariate analysis. They have only included the criteria in which the univariate analysis which were done has shown a p-value of less than 0.1 only. So that could not give a good control of confounding. They would have been a good outcome if they have included all these characteristics, major characteristics, into the multivariate analysis. And also they have not included AKI. They have given data based on CKD patients. They have not included AKI, which would create a more drastic outcome in patients in ICU because it's an acute condition. And also they have given a fixed FiO2 of 0.5. This is an observational study. They have not clearly mentioned how 0.5 can be fixed. That would again lend them into this is a some randomized control trial. So again, there's some bias there, and it's a single-centered study and an observation study, and that does not give an adequate amount of power to conclude that the outcome is reliable. And again, the monitored oxygen values were only 48 hours. They have checked, I've already described previously, they have stratified the patients when they fit into the septic and septic shock criteria, and they have followed these patients who had in PO2 and followed these patients PO2 of more than 100 and less than 100 for first 48 hours. And they have given an outcome based on the first 48 hours data. So only 48 hours does not give a complete outcome of a patient, does not describe the complete outcome of patient. It could have been a little more longer duration to check whether it had any effect on the outcome. So, thank you.
Thank you, Dr. Neeraj, for giving an elaborate explanation on this journal update. So as you said, the author reports the result of a secondary analysis of a prospective cohort here. And in this, they have been differentiated between PO2 less than 100 as low normal, low oxygen, and more than 100 as a hyperoxia. And they have studied the baseline PO2s, and they have concluded that there is a reduced 90 days mortality, as well as shorter length of the mechanical ventilation, and also the increases survival time. But we feel that the certain aspects of this study's design and data analysis warrants greater clarifications to facilitate the drawing accurate conclusions. So because there are, as you said, there are a lot of limitations here, because it's a single-centered observational study with a secondary analysis, because most of the confounders which are shown here, significant difference like chronic lung disease, respiratory sepsis, septic shock has not been included in the multivariate analysis. And also here in the hypoxic group, we are having more sick patients, more septic shock patients, higher Apache 2 scores, higher CRPs, as well as in the hypoxic patient, we are having the PaO2s, FaO2s lower, as well as in the hyperoxemic patient, we are having the less CRDS patient, which can have a biased this one. Okay, here the author has ascribed benefit with the hyperoxia to oxidative killing and better neutrophilic function in an environment of higher tissue oxygenation. But in sepsis, as we all know, that microcirculatory abnormalities are very common, and higher PO2s in arterial blood may not be equal to as higher tissue oxygenation. So, and the other thing is here the FaO2 in both groups has been used as 0.5, but in details we are not having ventilator strategies. So, and also the oxygenation was monitored up to 48 hours. So in order to conclude and change our practice, we need a robust RCTs to conclude that how we should go ahead with the usage of this oxygen optimal levels. Yeah, it's out to discussion. Yeah, Dr. Heyman.
Yeah, very good talk. I think we should first give chance to the participants.
Yes.
Feel free to ask questions.
This for the viewers. Our speakers, Dr. Said, Dr. Prabhu, as well as Dr. Neeraj are there. You can share your questions, please.
There is one
something
question
we are having here. Yeah, we are having in the chat box. What is the SpO2 target in COPD patient with heart failure or myocardial infarction? Is it 88 to 92 or 94 to 98? Yes, Dr. Prabhu, please.
So actually the SpO2 target in COPD and the ICU ROX trial, what I showed, so in there is subgroup is there. So in that, if we maintain lesser or more, it does not show any benefit. But from our previous experiences, we used to maintain, or probably we are actually being taught to maintain a lesser PO2 level in especially COPD patients. But the problem is that the concept has been slowly changing. It is not that if you provide oxygen, you will lose the triggering and you won't breathe. So it's not like that. The slowly concept is changing. The problem is your patient requires more oxygen, we can give. But the only thing is debate is don't give more oxygen to deliberately achieve a higher PO2. So you can give a decent good amount of oxygen. For example, if you are giving oxygen of 40% FaO2 and you are maintaining a saturation of 100, so you can come down on FaO2, you can give a FaO2 of 30. If you still patient is maintaining around 98, 99, you can still come down like 25. If he is maintaining 97, well and good. But the question is, if you are more of a restrictive, then you'll be finding ways to still bring down your SpO2 from 97 to 92. That is the thing we are not actually want to do here. We are actually allowing little more oxygen so that we are not more restrictive. But in the same case, if you are having a FaO2 of 40 is maintaining saturation of around 93, I'll be a little more cautious bringing down to 30 to maintain around 90. So I'll be okay enough to allow the patient with a saturation of 92 to 94, because the saturation 90 to 94 may be with a different PO2, and depending upon patient having shock, other factors, this value may be confounding. So better I keep SpO2 targeting little higher, so that my PO2 is always more than 60. That's practically we'll do, not in COPD itself, almost in all patients.
Yeah, ideally in sick patients, we have to go by the target wise, maintaining the SpO2 depending upon the disease severity. So, sure. Thank you, Dr. Prabhu.
I can see one more question in the chat box regarding oxygen reserve index.
Yeah.
For
Can we use oxygen reserve index for monitoring hyperoxemia?
But actually, like how Sarah told, and that there is no marker to tell hyperoxia existing. There is no biochemical marker or metabolic or any other parameter to tell that hyperoxia is happening. But only a problem is oxygen reserve index will tell you how much is a reserve capacity left over. For example, how much they can tolerate if you slowly reduce oxygen. So how much is the reserve capacity? That won't tell you that how much is the PO2. Like when you pre-oxygenate patient, so when you give more oxygen for bronchoscopy, other procedures to maintain higher PO2, so that they tolerate the procedures, so that your drop in saturation will take a little longer time to happen. So in that case, but it will tell you how long you will tolerate, but it won't tell that if the index is more, that means it's more harm is going to happen. So other way around, it will tell that he is going to tolerate and hypoxia a little longer time. That means it is going to take a little longer time for a PO to come down to 60 and below 60. So that's the way to interpret, rather than the way that if he is taking longer time, so that hyperoxia is existing. So it is very difficult to prove. There is no causal association between hyperoxia as well as the outcomes. That means hyperoxia is there, it is directly leading to some kind of adverse event that is not there. So it's very difficult, but oxygen reserve index slowly coming up, but it is not being regularly practiced nowadays.
Yeah. Dr. Nabil, Dr. Said, anything to add?
Regarding oxygen reserve index, sir?
Yeah, regarding the first question, regarding this COPD or heart failure.
Yeah, if we go by the physiology, we know that oxygen may lead to hypercapnia in COPD patients who are spontaneously breathing. But it's also important, as Dr. Natesh said, to avoid hypoxia, because even in hypercapnic respiratory failure, what kills first is hypoxia. So too low oxygen levels or too low SpO2 is not safe, but the guidelines say to keep the SpO2 levels between 88 to 92%. But as far as mechanically ventilated patients are concerned, the trials have not shown any difference between liberal or conservative oxygen therapy in the COPD patient, although the severe COPD group has been excluded from the trials. They have not included severe COPD in these trials. Only the COPD patients who are not severe, that is on supplemental oxygen or on room air, were included in these trials. As far as regarding ORI, I'm not sure much. I think Dr. Natesh must be knowing better, as told about it.
Yeah, so thank you, Dr. Prabhu, as well as thank to Dr. Said. Yeah, any more questions, please?
Any study where the post-operative transplant patients, we should target little higher PO2s, like close to 100, where the organ takes up well and the outcome is better? Did you come across any study? Because we have seen such practices where in the post-operative liver transplant, the surgeons are especially targeting little higher PO2s, close to 100. Less than 100, they are very restless. Any studies like that? We have failed to convince them at times.
So I have not come across any major good called randomized trials. But one thing is, if it is a lung transplant, then the giving excess oxygen may be a little detrimental. They used to target little on lower side. But if it is a transplant from GI, like liver, kidneys and all, so still people are little targeting little higher PO2, at least 80 to 90 rather than 60s. Because the only worry with liver is they are usually associated with more bleeding and hypotensions during intra-op and post-op. And even during kidney, some kind of sympathetic loss can be there, leading to hypotensions. So such scenarios they used to maintain PO2. Like the way it is detrimental to have anemia, hypoxia, as well as a low perfusion. So in that state, they usually maintain. And but I'm not sure whether to maintain 100 and more, but it should be decently okay enough to maintain 80 or 90, because the safety margin will be good enough. Unless if you target 60 and 70, then we may land up in a little lesser oxygen for longer time. So that may be detrimental in this population. And because liver as well as kidney, they are more prone for vascular complication post-op, even thrombosis and graft rejections. And renal cortex usually uses more oxygen. So that's why people little more worry about exposing a patient to hypoxia. But it's very difficult to prove data is not there to show that 100 or 80. But surgeons are taught in a way that you maintain more. So we people are taught in a way that you maintain less. So this game is not going to get over.
Yes, really, we had an excellent debate on this topic because this has been started by because I have gone through the literature regarding this. Because Joseph Priestley, who is credited with discovering oxygen, was himself wary of oxygen that actually suggests it might be harmful. So Priestley noticed that a candle burnt out faster in pure oxygen as compared to air. And just as the flame needs oxygen to live, it also dies faster when exposed to an excess of oxygen. Then only the Priestley thought that similar way, it may happen to our cells, and that it turns out to be he wasn't wrong at that time. So just at that moment, I'll just memorize an American novelist words that perhaps too much of everything is as bad as too little. Okay. So with this, we are going to, can we going to conclude, Dr. Hemant? Yes, are we having any questions? Dr. Hemant, Vinay?
No, sir. There is no questions here.
Yes. Once again, thank you, Dr. Prabhu, as well as Dr. Said and Dr. Neeraj, and all the viewers for excellently and enthusiastically participating in our academic program. Thank you one and all. And also thank you for the organizers.
Thank you very much, sir, for moderating well. And thank you everyone for the opportunity. Had a good time in this evening, and good to meet many of my known people now. Thank you very much.
Thanks a lot, sir.
Thank you, Dr. Sheikh Arif. Thanks, Natesh. Thanks, Neeraj. Thanks, Dr. Syed.
Yeah, Dr. Hemant, can we leave now?
Yeah, I think Dr. Karthik.
Yes. Thank you all for having patiently been with us. Thank you very much. Wonderful topics, fantastic presentation. Thank you, everyone. I think we'll conclude this talk today. We'll meet again for the next meet soon. Thank you.
Thank you. Bye.
Congratulations.